Assalamu alaikum. Now the neurology history based on disease. This history may come with the scenario just like this. A 7 years old child now present with there is deterioration of school performance and some abnormal movement. So take the detailed history. So just like other history, introduction, rapport formation, and taking permission to take some note, and then asking a brief question, what is your main concern? And then mom may present that the child has deterioration of his school performance. So can you will please tell detail about that, what he was able to do and what he can't do, and when you notice it, does it progress, does it the condition remains the same or the change over the period of the time, and did you notice any unusual behavior? Do you have any concern regarding his speech, that means dysarthria? Then ask about the constitutional symptoms of, do you have any concern regarding his weight? Does he have any kind of fever? What's about his sleep, his activity? And a systemic review. Systemic review from CNS, we can ask that any weakness, any part of the body, any kind of seizure, feet, any unusual movement do you notice, and any gait disturbance, and GIT, we can ask yellow coloration of skin, and any tummy pain. What's about his bowel habit? Do you note what's about his pee? Do you have any concern? Because it is associated may with associated renal tubular acidosis. Any joint pain or gait joint abnormality, and any kind of pallor palpitation, because Wilson may presence with palpitation due to cardiomyopathy. And as there is uh, deterioration of school performance, so as a differential diagnosis we can also ask about hypothyroidism. So in the endocrine history, any hot or cold intolerance. After the systemic review, just as usual, history, past, perinatal history, development, growth, dietary history, vaccination, allergy. And then important history, the family, consanguinity and marriage, and any history of similar any condition in the running in the family, social history, schooling history, and any kind of school bully. And our differential diagnosis, as the child is more than 5 years, so Wilson disease, ataxia telangiectasia, Friedreich's ataxia, SSPE, and adrenoleukodystrophy, and juvenile Huntington, and psychological hypothyroidism maybe. So for Wilson disease, what examination if it is Wilson disease? So examination, vital sign, pallor present or not, and skin pallor, and eye cave-ring. Better it will be seen by the slit lamp examination, para-abdomen examination for features of hepatitis, and portal hypertension may be present, formal neurological vision, and MSK examination and investigation. So it's a Wilson disease here, autosomal recessive disease, and mutation of ATP7B on chromosome now 13 involved in copper transport. So the net result will be reduced ceruloplasmin in blood, and accumulation of free copper in hepatocyte, and copper induced toxic injury to the hepatocyte, and spilling of the free cover from the liver into circulation. And this induced toxic effect causes injury to the RBC. For this reason, there is hemolysis, basal ganglia, cornea, kidney, bone, joint, parathyroid gland, and there is concomitant urinary copper excretion. So the In clinical manifestation in the liver, there will be acute hepatitis, fulminant hepatic failure, chronic liver disease such as portal hypertension, ascites, and nervous system extrapyramidal manifestation, tremor, dysarthria, drooling, dystonia, choreoathetosis, psychiatric manifestation, dementia, deterioration of the handwriting, school performance, speech disturbance, in IKF ring, sunflower cataract, other hemolytic anemia, rickets, renal tubular acidosis, arthritis, cardiomyopathy, hypoparathyroidism, infertility. So investigation. Diagnostic investigation is genetic test. And supporting investigation, serum hemoglobin decreased, ceruloplasmin level decreased, 24-hour copper excretion increased, HTPT prothrombin time may be increased, MRI of the brain reveals changes in the basal ganglia, deep penicillin challenge test, yeah, and here the copper excretion will be increased, and liver biopsy to measure hepatic copper content. And management via multidisciplinary team, pediatrician, neurologist, hepatologist, dietitian, nephrologist, genetist, ophthalmologist, speech and language therapist lies with school. And supportive management and specific management. Supportive management is d-penicillamine if it is not tolerated, so dianti tin hydrochloride and other supportive agents, zinc acetate. This zinc will prevent copper absorption, and here we use zinc acetate because it is less, it causes less gastric irritation, and other we can use the pyridoxine. And diet, we will tell counseling regarding the dietary advice: avoid shell, fish, nut, chocolate, and specific is liver transplantation. Thank you. Assalamu alaikum.